again, welcome to the Grand Rounds. So it's my pleasure today to introduce our speaker today, Dr. Gary Farkas. Dr. Farkas came to us from the University of Miami Miller School of Medicine and also the Miami Project to Cure Paralysis, where he spent his final years training as a postdoctoral fellow and recently was appointed as assistant professor of physical medicine and rehab there, and also with a secondary appointment in the Miami Project to Cure Paralysis. So Dr. Farkas is a kinesiologist by training and then received his PhD in anatomy from the Penn State University College of Medicine. Last year, he also completed a master's degree in clinical and translational investigation from the University of Miami Miller School of Medicine. So Dr. Farkas' research centers around obesity after spinal cord injury. He's particularly interested in the interplay of multi-level factors that influence energy metabolism, appetite regulation, and eating behavior, leading to the neurogenic obesity after spinal cord injury. So his research has been funded by multiple institutions and private foundations, including the Craig Nielsen Foundation and the American Association of Anatomy. He has authored more than 50 peer-reviewed journal articles and 5 book chapters. His work has been recognized by multiple awards from local and national organizations over the year. So I'm very excited to have the opportunity today to learn more about his research. Without further ado, please join me and welcome Dr. Farkas.
Thank you, Dr. Chen, and thank you to the Department of PM&R at UAB for the invitation today to give this lecture. So at the lunch hour, we're going to be talking about what people eat, specifically folks with spinal cord injury and obesity, and the role of eating behavior in this. So let me go. There we go. Okay. My disclosure, my current funding. I think there's a little bit of a lag. There we go. So our learning objectives for today are to describe the factors that contribute to the development of neurogenic obesity after SCI, examine the unique factors of SCI that limit energy expenditure, leading to an increased tendency for overeating. And then we're going to explain the rationale for identifying and intervening in factors that promote overeating after spinal cord injury using novel biobehavioral approaches. So before we begin, I want to take a minute and actually define what obesity is. So let's first start off by saying what obesity is not. And we all know that obesity is not BMI. Instead, it is a chronic, progressive, and relapsing neurobiobehavioral disease with a distinct pathophysiology that is sensitive to environmental conditions. It's also interregulated dysregulation of genetics, adipose tissue, metabolism, central regulation of food intake, and energy expenditure, as well as behavior. So it is a quite complex disease. Now, within the US, 1 in 4 adults are said to have a disability, so it's about 27% approximately. And of this group, about 42% are with obesity. So when we talk about obesity, I think it's really, really important that we characterize how it is actually assessed. And most people are familiar with anthropometric measures, such as body mass. There's a new one that was just published a couple of years ago called the Body Roundness Index. So it uses a geometric formula that estimates a person's body shape and composition. And it's been in the literature for a while, even though it's been relatively new. However, it's not been looked at in spinal cord injury. We also have diameters, waist to hip ratio, and then we also have the waist to height ratio. And then what most people are familiar with are circumferences, such as waist circumference, abdominal circumference, and body mass index. Now, body mass index has been around actually since the late 1700s. It was first called the Quetelet Index. And in the 20th century, it really was adopted as the main metric to assess obesity. And we know that we have our 5 categories of obesity down below, but we also know these do not work for spinal cord injury. So instead, we really need to rely on body fat assessment when it comes to examining obesity, or using the SCI specific cutoff of obesity of 22. So by definition, total body fat above 22 in men and above 35 in females is classified as obesity in any population. We also have regional markers of obesity, and this is particularly looking at visceral adipose tissue, sometimes called organ-specific adipose tissue. And it also includes regions such as fat in the limb and fat in the upper limbs and lower limbs. And, fat is assessed through multiple mechanisms. We have underwater weighing, bioelectrical impedance analysis. We have advanced imaging with MR and CT, DEXA, and so on. So when we talk about obesity after spinal cord injury, it really is unique and somewhat veers away from the normal definition of what we typically think of obesity in terms of how we characterize it and measure it. And neurogenic obesity, the late Dr. Gator and I published a paper in about 2017 defining it. And it's important to understand that neurogenic obesity reflects an excess amount of total body fat. And it occurs as a result of motor paralysis below the level of injury, the obligatory myopenia that occurs due to the loss of protein below that level of injury, sympathetic dysfunction from thoracolumbar damage to the cord, anabolic insufficiency. So there's, for example, a decrease in testosterone and increase in cortisol. And then we have a decrease in energy expenditure. And it's important to point out that this decrease in energy expenditure is really secondary to the changes in body composition. And there is some emerging evidence in our field of appetite dysregulation. And I refer to appetite dysregulation, I'm not referring to the less intake that occurs after spinal cord injury. I'm really referring to feelings of hunger and satiety that we'll talk about a little later today. So over time, we have seen in the population that obesity has progressively gotten worse. So this is some data that we have under review right now from an extremely large systematic review and meta-analysis, where we had in total for some of the analyses, we had about 30,000 people. And what we did is we collected data on several metrics, including body mass index, visceral fat, and total percent body fat. And we looked at the trajectory over time to see if obesity is worsening. And you can see in these figures on the x-axis, we have time, the y-axis is specific metrics, so BMI, total body fat percent, and visceral fat. And with regards to BMI and percent body fat, we see that it is significantly increasing over time. The blue line is a trend line, it's a regression line, and the black dots are the individual sample sizes from various articles. And the size of the circle represents the weight that article provides to the analysis. So, overall, we could see that this is increasing over time, but interestingly, visceral fat is staying relatively the same over time. And this sort of should not be surprising because we see within the general population with those without a spinal cord injury that obesity has also increased over time. So there's a lot of different theories about the role of adipose tissue from obesity mediating metabolic risk, so cardiovascular disease and cerebral vascular disease, et cetera. And while there is a large amount of research that does point to fat mass increasing metabolic risk. There's also research that says the opposite. But for the most part, within the field, within spinal cord injury and outside, it's generally well accepted that the increase in body fat results in a increased risk for metabolic syndrome. And you might expect or might think that, fat is just a normal organ that stores triglycerides, but we've known for a while that fat is inflammatory and it is metabolically very active. And when fat increases, it loses its plasticity and becomes dysregulated. And as a result, it will start spewing out free fatty acids and pro-inflammatory molecules. These pro-inflammatory molecules enter the circulation along with the free fatty acids, and then the free fatty acids are deposited throughout the body in different organ tissues. And along with these inflammatory markers, they interfere with normal signaling cascades. And the manifestation of this interference is through conditions that we, or clinicians, diagnose, such as dysglycemia, dyslipidemia, hypertension, etc., in this population. And when these conditions co-manifest, they create a condition called cardiometabolic syndrome or metabolic syndrome. And, there's a lot of debate if metabolic syndrome is actually really a thing, but it's important to understand that regardless of how you define metabolic syndrome, it's increasing your risks for cardiovascular disease, cerebral vascular disease, and ultimately death. So it is a pretty big risk factor for cardiovascular disease. So when we talk about obesity, you really can't talk about it without looking at energy balance. So energy homeostasis is very tightly regulated in a very complex system. But with all the different components of energy homeostasis, you can still sum it up as two components. There's an output, which is your expenditure, and then there is an input component. But it's also really important to know that there are multiple influences that are somewhat external that influence our energy homeostasis. So these are environmental signals, psychosocial parameters, socioeconomics, medications, and then hedonics. So when we talk about energy homeostasis today, we're going to really simplify it in a sense that it's intake and output. So energy balance by definition is energy in is approximate to energy out. And somebody who is in this state is weight stable. Now, for the most of us, that is very uncommon. We typically fluctuate between a positive and negative energy balance. And a negative energy balance is where your intake is less than what you are expending, and it leads to a weight loss. On the other hand, a positive energy balance, which is not a good thing, is when the intake exceeds the output. And this is where weight gain occurs. And it's important to understand here that this intake is in excess of what the expenditure is. So somebody might be eating more than what their energy needs are, still is going to gain weight, even though they might be expending a certain amount of calories. So a positive energy balance in the population without spinal cord injury is pretty well defined between anywhere from 10 calories per day to 100 calories per day. And we've previously shown in spinal cord injury that our folks are consuming about 160 calories in excess per day, leading to a positive energy balance. And I think it's really important that we talk about positive energy balance to understand there's two components here that are contributing to excess energy. We have the intake component, but we also have the decreased energy expenditure component. And together, those two components are influencing our system where there is an excess amount of energy that needs to be stored. And this is unique because in spinal cord injury, we know that there are multiple factors that vary from the non-spinal cord population that contribute to this unique phenomenon. So now we're going to take a little bit of a turn and we're going to talk about energy intake. In 2019, I guess this paper's getting a little old now, we published a very large meta-analysis looking at energy intake and macronutrient consumption in folks with spinal cord injury. And you'll see in this first line here, energy intake in spinal cord is about 1,900 calories. And in the general population of those without SCI, it's about, 2,200 calories. So we know that spinal cord injury folks eat less than those without because of decreased energy needs. But if you look at the macronutrients, protein, fat, and carbohydrates, generally our folks with spinal cord injury are consuming a very similar amount of macronutrients to folks without spinal cord injury. And again, this should sort of make sense because they, after being discharged from rehab, they're back in the community and the foods that are available are the same to what's available to somebody without an injury. What I do want to point out is carbohydrates. This is a little unique that while this is still within range of what's recommended by the USDA, so this is Dietary Guidelines for America, carbohydrate consumption was a little bit on the high side compared to folks without SCI, and we'll revisit that a little later in this talk. So energy requirements can be measured or they can be estimated. And when you measure energy requirements, it uses a technique called double-labeled water, which is quite expensive. So there have been several methods that have been published that allow us to estimate energy requirements in folks. So the Institute of the Medicine of the National Academies has some regression equations that are sex-specific, and they use age, physical activity factor, weight, and height to determine energy requirements. And then there's two other methods that are called the simplified factorial method. And this uses basal metabolic rate or resting metabolic rate times an activity factor. So this corrects for physical activity. And then that will give you total energy expenditure. But in somebody who is weight stable, that can be assumed to be equivalent to energy requirements. So therefore, sort of the bottom line is that you can use this equation called the long equation to determine energy requirements. Now, in 2019, we published a paper where we developed an activity factor that's specific to spinal cord injury, and it's about 1.15. And this used the metabolic equivalent of tasks of MET that's specific to spinal cord injury of 2.7. So what we did is we looked at energy requirements relative to what is actually being consumed by folks with spinal cord injury. So on this x-axis, you're going to see the absolute consumption in this figure, and you'll see the intake method here. And in the y-axis, you'll have the number of calories that are being consumed. So the actual amount here is about 42 individuals with about 1,500. And based on the estimation method, this goes up as you move to the right. So what we did is we took the delta between what they're actually consuming and what the method is actually describing they should be eating. So for example, the SCI specific factor minus what they're actually consuming. And you can see on the right that the SCI specific factor to estimate energy requirements was the only one that did not overestimate energy intake, which should not be surprising. And the long method and the IOM method both significantly overestimated their intake. So this slide here reiterates that, and it really just shows that the SCI method had the smallest mean bias, the best level of agreement, and we also had the least amount of error and the smallest reporting bias. So for those of you who aren't familiar, reporting bias is used for dietary intake logs, and it tells you how much somebody is underreporting or overreporting on their food diaries. So in this case, we had the smallest amount. So what we can ultimately see here, which should not be a big surprise to the audience, is that we must use SCI specific methods for energy requirements. And while this should seem pretty obvious, in the literature, in our field, it is still not being done. People still often use the long method, 1.2, which does overestimate the requirements. So, and the importance of this is in clinical practice, obviously, that if you're using these methods to determine intake or in a research study, you can lead to overfeeding and then consequently contribute to the pandemic of neurogenic obesity. So we're going to talk about protein, and there is an equation for estimating protein intake as a function of body weight that was put out by the Academy of Nutrition and Dietetics from 2009. And it says that folks with a spinal cord injury who are community dwelling, that are back in the community, need to consume 0.8 to 1 gram of dietary protein per kilogram of body weight per day. So this is interesting because for the non-SCI population, somebody who is not physically active, the recommendations are 0.8. So this is sort of implying that more protein is needed after SCI, which is a very controversial topic. But what I want to point out here on this figure is that what we're seeing is a phenomenon with increasing body weight. There's a shift in the amount of protein that is being consumed. So the x-axis are the individual participants by body weight, increasing body weight. Y is protein intake. Triangles are those folks who overconsumed. Circles are those who adequately consumed. And squares are those folks who are under-consuming. The gray lines here represent the estimated amount of protein that should be consumed as a function of somebody's body weight, so 0.8 to 1. And what we saw here is that only 16% of folks in our sample were consuming the recommended amount of protein. So what we did next was we regressed protein intake on body weight, and we did not see a significant relationship in that, which is actually contrary to what the recommendations are with folks with SCI. So what we did next is we took the delta of what was actually consumed and what is recommended, and we saw a very interesting trend. And what we're noticing is that as body weight increases, protein consumption is decreasing. So what we want to see is at what point does this actually occur? Where is the shift going from the amount that is being overconsumed or adequately consumed to where somebody is under-consuming protein? And this value happens to be at 72.4. And so folks eating, below that amount, 19% were under-consuming protein, whereas above that, 85% were under-consuming protein. And protein is, a satiating macronutrient, and it does help to prevent later intake. So when you are not consuming adequate amount of protein, it can lead to additional overconsumption. So what I want to do now is take a minute and then apply some of these values that we've sort of been talking about. So the energy intake here is this from the meta-analysis that we published, and then the measured RMR here is also from our meta-analysis. And you can see on each side, we have the long method, which is the non-SCI method. The 1.2 is considered for sedentary activity, and then the 1.15, which is considered for our folks with SCI. And what we did is, doing some math, we were able to calculate out the number of calories that are being consumed in excess. So in the SCI, non-SCI method, it's about 600, and the SCI method, it's about 1100. And then we were able to convert that into fat gain or weight gain over the course of a single month. So in 1 month, using the calculation for non-SCI, it's about 9 pounds of fat in a year that would be gaining, versus if you use the SCI method, it will more accurately reflect about 17 pounds, almost double that of the non-SCI method. So if you don't use that correct value to estimate needs, then ultimately you can be, again, contributing to the overconsumption of food and also neurogenic obesity. So it is very true that these values do not include any kind of physical activity, but I will say that we know from Kathleen Martin-Guinness that about 50% of folks with SCI do not report any type of leisure time physical activity. So several professional organizations have published activity recommendations, physical activity recommendations for folks with and without spinal cord injury. Obviously, the big notable one is the one on the right from the Paralyzed Veterans of America that Dr. Mark Nash, who's here with me at the Miami project, led. And they all have recommendations for physical activity. But guess what? They all say the exact same thing. At least 150 minutes per week of moderate to vigorous intensity activity, muscle strength training for the major muscle groups 2 times per week, and then flexibility. It's the exact same thing. Now, there is one set of guidelines from the American College of Sports Medicine that are a little bit on the older side, but they have not been updated, that talks about weight loss and preventing weight regain. And they say that in order for somebody who needs to maintain body weight, it means they lost weight and now needs to maintain that, or they need to lose weight, they need to expend about 2,000 calories per week, equivalent to 250 to 300 minutes per week of moderate intensity. This then leads to a clinically relevant decrease in metabolic risk, and that's about 5 to 10% decrease in body weight. So somebody with a spinal cord injury who's 200 pounds, that means they need to lose about 10 to 20 pounds over time. So we showed after 16 weeks of exercise training that while energy expenditure did increase, and while body fat decreased, body weight did not change. And we really didn't see any kind of improvement in cardiometabolic health. So this shouldn't be sort of surprising because we know that the activity thermogenesis in somebody with a spinal cord injury is less than somebody without. And this has been well shown by many, many labs in the US and overseas that this is the case. And we recently published a paper last year where we looked at different activities that are common in spinal cord injury. And then we also looked at the amount of oxygen consumption that is occurring during that activity. And we converted that to calories per minute. And then we were able to extrapolate that over the course of a week to see how much time somebody with a spinal cord injury would need to spend doing that activity in order to get the benefits of expending 2,000 calories. And we saw that, especially for higher levels of injury, it's upwards of close to, 500 minutes over the course of a week. So here are some calculations that kind of go through what it would look like if our folks were expending or exercising 150, 250 to 300 minutes a week. And the main thing I want you to take away here is there still is going to be a positive energy balance, regardless of the amount of activity that is occurring. When the recommendations, for the max amount of 300 minutes a week is reached. So this brings us to sort of the next part of the talk. So I want to point out that while we really have a strong evidence base for the factors that contribute to neurogenic obesity in the early phases of injury, we really do not understand what is driving neurogenic obesity in the chronic phase of the injury. It's much more than sedentary activity. It's much more than the overeating component. We really need to get at the factors that are contributing to that. And, we tell folks to eat less and engage in 150 minutes per week of activity. But the interesting thing is we also know that the metabolic benefits, so the caloric expenditure at that volume of activity, is different than folks without a spinal cord injury. So I asked this question, is it time for a new approach? So we start looking at the factors that are promoting overeating after SCI. So a collaboration that I have with Barbara Rolls on the top, and her former graduate student and now postdoc, Paige Cunningham, we set off to look at some of the factors that contribute to overeating. Specifically, we looked at satiation, which is the reason why somebody stops eating when they're eating. So when it comes to meal termination, it's not just about feeling full. There are several different factors that contribute to that. There's what's called the planned amount. This is the amount of food that before you actually eat, you are actually going to pre-plan to consume. There's self-consciousness. This relates to, well, as it sounds, self-consciousness, feeling self-conscious about what you're eating. So for example, if you went on a date and your counterpart ordered a salad, you might order a salad. Or if they took a doggy bag, you might take a doggy bag to go. So decreased food appeal, this refers to a concept called sensory specific satiety. And this is when food is no longer rewarding. So you kind of get tired of eating it and therefore you stop eating it. Then there's physical satisfaction, right? So the stomach is expanding in volume, and that is a very well-known factor to contribute to satiation. And then decreased priority of eating. This relates to the hedonic decline in food that occurs as you eat. So we looked at these factors in a survey, this was during COVID, in folks with and without SCI, and we had a very large sample size, about 600 in SCI and I think about 400 in the control group. And what we saw is that, physical satisfaction and planned amount were significantly lower in folks with SCI. So they said that folks with spinal cord injury said that they were less likely to stop eating due to physical satisfaction and planned amount, but they were more likely to stop eating because of decreased food appeal and decreased priority of eating. So what this is actually telling us is our folks are relying less on physiological cues coming from the stomach for satiation and more relying on hedonic and food reward. We also asked about preparing a meal at home. So who prepares the meal, who serves the meal, and who they ate with. And what we saw is folks with spinal cord injury were less likely to prepare their food and serve their food, and they were more likely to eat in a social setting. And individuals who eat in social settings have less, have more, they're more likely to overeat. And folks who are less likely to plan what they're going to eat are also going to likely to overeat. So next we looked at the frequency of meals and snacking. And here we saw that the total number of eating frequencies, so total number of eating occasions, which is basically the sum of the number of meals and the snacks that were consumed, was significantly greater in folks with SCI. So the red here is the purple here is controls, and then yellow is SCI, and the y-axis is frequency. So folks with SCI were consuming more eating occasions over the course of the day compared to the controls, and this was largely driven by increased snacking. Additionally, folks with SCI were reporting that they were consuming less breakfast, lunch, and dinner throughout the week than controls. Now, I want to take a moment and focus on snacks. Remember earlier I mentioned that carbohydrate consumption was a little greater in spinal cord injury than the controls. And this could be what is driving that phenomenon, because snacks are being consumed more, and snacks are often higher in carbs. They are fat, contrary to popular belief. So that could be what is driving this phenomenon. So what we're able to conclude here is persons with SCI have less preparation autonomy when it comes to meal preparing. And this might result in an increased amount of snacking and the consumption of less meals. And when you consume less meals, you might be eating those single meals in larger portions. And it's important to also understand that snacks are prepackaged, they're highly palatable, energy dense, and they're easy to eat quickly. And these are known factors that drive overconsumption. So this data led us to my funded Craig H. Nielsen Fellowship, where we looked at physiological and behavioral factors of feeding in spinal cord injury. So this was a 2-visit study. Our folks came, they had a DEXA scan, they did some questionnaires, and then we asked them what's called a hunger series visual analog scale, how hungry they were, how much food they think they can eat, and how full they feel. And we then serve them a meal, and this meal was bread, eggs, and jam. It was all weighed out, so it was the same quantity each time. Following the meal, our folks then consumed the SMART pill, wireless motility capsule. This is a tool that is used to look at gut motility. And then for 2 hours after that, we assessed satiety using that hunger series visual analog scale. The data that's below, or the below, is the second part of the visit. And this is when they would come back and they would return the recording device that was used for the SMART pill. And then we did another series of questionnaires asking about their hunger. And we provided them a second meal. In this visit, we also drew blood. That data I will not be sharing quite yet. This meal was also doubled in size. So it was about 510 calories compared to 250 calories here. And then again, over the course of 2 hours, we assessed their satiety. So this is the breakdown of the group. This was a pilot study. So we had 16 controls. Folks were gender and age matched, and you can see that we have 100% male in our sample. And then all the parameters here were not significantly different. We had 8 paras and then 8 tetras, and then we included folks who were motor complete and motor incomplete up to C. And time since injury was about 18 years. So the data here is looking at the gut motility. And as we know from the literature, generally speaking, gut motility is delayed. So the x-axis is our controls. On the left, the y-axis is going to be, assuming the x-axis on the right is our folks with spinal cord injury. So it's like orange and turquoise. And then the y-axis will be our time for the specific motility measure. So we saw that upper gut transit time was significantly delayed in spinal cord injury, and upper gut transit time is gastric emptying and the small bowel combined. And we also saw that colonic transit, intestinal transit with its small and long, a small and large intestine, and then whole gut transit were delayed. But interestingly, the gastric emptying time trended towards a difference in our data. So we looked at the area under the curve for our satiety measures. So we took all the postprandial measures for our time points from immediately after they ate till about 2 hours after they ate. And then we calculated out the area under the curve, and we compared it between the two groups. So area under the curve is on the y-axis, the x-axis, and then our groups are on the x-axis. And you can see that the only difference was prospective food consumption. And this should not be surprising, because what we're basically asking is how much food can you eat at a given moment? And folks with SCI generally said that they could consume less food than those without. And this is not surprising given the lower energy requirements. But hunger and fullness were not different. So we looked at the associations between gut motility and satiety. And this is a very busy figure, and I'm going to break it down for you in a minute. And what we looked at, these are going to be the significant findings that we found. So for our main effect, we saw a significant association between small bowel transit and fullness. So when we adjusted for group for each increase per hour in small bowel transit time, there was an association with greater fullness. And then this also trended along with small bowel with gastric emptying as well. So for group effect, we did see some significant differences. So for the same small bowel transit time, men with SCI reported less prospective food consumption compared to controls. And for the same small bowel transit time, men with SCI reported less fullness and more hunger than controls. So what this is telling us is that our folks with spinal cord injury are having the opposite effect. So typically, as transit time increases, you should feel more full and less hungry. But with the injury, we're seeing that opposite phenomenon occurring in our folks with spinal cord injury. So we also noticed a significant interaction. So fullness showed a weaker negative association with small bowel transit time, and then hunger showed a stronger positive association with small bowel transit time. So this interaction is basically telling us that this association between bowel transit and our satiety measures, the strength of this association is different between our two groups. So in conclusion, what we're seeing from that data is gut dysmotility after SCI may mediate altered hunger and fullness sensations by disrupting brain-gut adipose tissue signaling, particularly from the small bowel. And this may contribute to overeating and neurogenic obesity after SCI. So the data I'm going to show here, this is really preliminary. We've just recently started analyzing this from the fellowship, but we didn't see group differences. So on the x-axis, we have time. The y-axis is our visual analog scale. Visual analog scale is how somebody measures satiety. And we looked at prospective food consumption, fullness, and hunger. And we did see a time effect when it was adjusted for baseline, but there was no group effect. I do want to note that the plots here are not adjusted for time, but in the analysis, it is adjusted for baseline time. So this is the larger meal. So that first one was 255 calories. This is 510 calories. So it is a larger meal. And we saw that same phenomenon here with the larger meal. So we're not seeing group differences, but we're seeing the normal time series effect that somebody would have. So immediately after you eat a meal, you'll feel more hungry and less full. And then as time goes on, you feel more full and less full and more hungry, and you're able to eat more food. Same thing was observed in both groups, but there was no group differences. But I do want to point out one thing that's really important is earlier we showed a difference in prospective food consumption between both groups. Our folks with SCI, when looking at the area under the curve, said that they could consume less food compared to somebody without an injury. So you would expect that when the meal size increased, our folks with SCI would have consumed less, or they would have reported even more fullness, but we didn't see that. So there's some sort of disconnect that we're seeing between satiety, like perceived satiety, and what they're actually consuming, the actual energy intake. And this is especially noticeable with larger portions. So this brings us to this phenomenon called the portion size effect. And maybe folks with spinal cord injury are not responding to the portion size effect the same way somebody without a spinal cord injury does. So the portion size effect is exactly what it sounds. That as the portion size increases, you consume more food. And you tend to feel more full as you do that. But we don't really know this phenomenon quite yet in our folks with spinal cord injury. Now, the other caveat to this, I will say, is we were piloted. So this pilot study was powered based on gut function, and the satiety measures were more exploratory. So at this rate, there is the obvious possibility that we were underpowered to look at this, but it's to be continued right now. So I want to end the talk today talking about appetite and food intake and eating behavior at a bigger picture. So there are so many different factors that influence our appetite and what we eat. Everything from the environment to physiological to the actual food itself that we are consuming. But there's three factors that we know that are really what we call the big three. That's variety, portion size, and energy density. So the portion size we sort of just spoke about, that as portion size increases, we tend to increase the amount that we consume. Variety is exactly what it sounds. When you have more variety in front of you, you tend to overeat. And for those of you who always say you have a second, stomach for dessert, what that basically is variety. You're introducing another food to the environment. And because it's providing variety, you will tend to eat more because we know variety leads to overconsumption. And the last one is energy density. And this is sometimes called calorie density. It's basically the amount of calories in a food, in a meal, in a day, divided by the weight of the food. We know that high energy density foods lead to greater overconsumption in those without spinal cord injury. But a lot of this, actually all of it, we don't know what the effects are in spinal cord injury. And it could be that in the chronic phases of the injury, that these are leading to neurogenic obesity and then the greater cardiovascular risk in this population. So I want to give you an example of what energy density is, because we're actually doing some work on this right now here at Miami Project. So on the left, you see a plate of potato chips, and on the right, you see a plate of strawberries. Their weights, so the volumes, are the exact same thing, but the calorie difference between them is very, very different. So when we calculate out the energy density, you can see that the energy density of the chips is 5.4, while the energy density of the strawberries are 0.4. We know that higher energy densities lead to greater overconsumption. And I'm sure at one point in your life, you've had a bag of chips with you and you just kept eating them and eating them and eating them. This is a known phenomenon that occurs with energy density. And versus the lower energy density, you can eat as many strawberries as you want, but the calories are much, much less than that of the potato chips. And you might ask yourself, why? Well, foods that have low energy densities, like strawberries, like grapes, produce is more so, you can kind of group all of that, but soups even, they have a higher water content. And the higher water content makes you feel more satiated, so therefore you eat less. We know that when the stomach expands, the volume increases, it drives satiety, and that is one of the founding principles behind energy density. So it's really important as we move forward in this field that we test out things like this, because typically our field of spinal cord injury and research, we're like 15, 20 years behind everybody else. And these are weight strategies that have been well published, well used in the non-spinal cord population that we need to start adapting to our folks with SCI. So I want to end really with this, I guess you could say, cliche that if you don't understand the problem, you can't effectively intervene in the problem. And dare I say, I know I'm being recorded, that a lot of the dietary interventions, a lot of our exercises interventions really don't lead to sustaining results, in part because we don't target behavior, and in part that we're not really using diet strategies that are going to be effective. DASH diet, Mediterranean diet, those are commonly reported and discussed in spinal cord injury research. But the bottom line is that if you eat too much of the DASH diet, the Mediterranean diet, it's still too many calories. And if we can get to a way where we can allow somebody to eat as much as they want of low energy density foods or mid energy density foods, we can maybe then start working at the problem of neurogenic obesity. So with that, I will take questions.